Hello, everyone. Great. Hi. Thank you so much for joining us today. We'll wait for 30 seconds more because I do see that a lot of participants are attending. So let's just wait for another 30 seconds and then we'll start the webinar today. Thank you.
The numbers are steadily climbing.
Okay. Hello, everyone. Welcome to the first session of AI in Public Health Expert Dialogues on Strategy, Governance, and Ecosystem Transformation, co-hosted by PATH and OECD and convened under the Public Health Impact through AI, the PhixAi initiative at PATH. My name is Resham. I drive the initiative of PhixAi at PATH, and it's a pleasure to share this space with each one of you. For those of you who may be hearing about PhixAi for the first time, it's a flagship initiative of PATH, a global platform to accelerate scaling of innovations at the intersection of AI and public health to sustainably achieve universal health coverage and health equity. Over the next 6 months, we'll explore what it really takes to integrate AI into public health, beyond hype, beyond pilots, and into systems that serve everyone. I will now request my colleague Eric from OECD to open the session and set the context for us, and welcome to everybody once again. Thank you. Over to you, Eric.
Thank you very much, Resham. And I do note that our number of attendees just crossed 100. So I think that is exceptionally important to note because it demonstrates the importance of this work. We had almost 400 people sign up for the webinar too. So I think that there is awareness. It's that AI is beyond hype. It is a consequential new tool in our toolbox to help health systems around the world do health better, more efficiently, more effectively, and achieve better health outcomes for people all around the world. So my name, as Resham said, I'm Eric Sutherland. I work at the Organization for Economic Cooperation and Development. My role at the OECD is at the intersection of all things to do with digital and all things to do with health, which I will say causes me many late nights. But I was in particular thrilled when Resham invited me to co-lead this series of webinars, because I think it is really important. We're at this really important moment where we have been doing things, we've been struggling with the health systems, and we have the ability to make meaningful progress now. As I heard in the podcast just this very morning, but it was a reflection from Ricardo Baptiste from Health AI, that even for those economies where which are more resource constrained and are less connected, it isn't. It is the right time now to start taking actions to prepare for the AI future, because the more that you wait, the more you'll fall further and further and further behind. And so there is great opportunity for us to collaborate and working together, which is why I'm so glad to be here. And the overall concept that we had for this series is to really discuss, as Resham said, these critical issues that we have in order to decide and understand what are some of the non-regrettable actions that we can always take in order to advance the responsible use of AI within our health systems. And ultimately is to spark discussion that leads to some sort of a coherent signal that clearly says these are things that we need to be all rowing in the same direction, where we all want to be heading. Overall, this is a monthly series. And I'll talk a bit more about that. So today's discussion is around designing AI for low connectivity and resource-constrained environments, which many parts around the world are experiencing that. And there is still massive opportunity, as we'll hear, to leverage AI even in those spaces. The future sessions that we'll have will explore areas of culture and putting AI into practice, the financing of the AI ecosystem, strengthening the invisible workforce of back office professionals that help drive AI's use in the front line, what we could be doing around regulation and in ethics. And overall, we'll wrap it up with a discussion around the global health diplomacy and where we see as the AI frontier going forward. Our ultimate aspiration from this series is to capture insights from all these sessions that are practical and implementable, that will help everyone realize both the economic and, importantly, the human potential of AI, because there's an enormous human benefit to be had if we collaborate and work together in order to achieve that. We aim to create actionable knowledge products in this space, and so that is the ultimate outcome that we have. And so I'm hoping that today's discussion, I'm sure today's discussion with our fantastic panelists will be really instructive and informative for everyone. We now have over 120 people, which is great and fantastic to see. And so I thank all of you as participants of this session today, because I think these conversations are only important if people are listening and acting based on what they hear. So thank you for everyone who's attending. And most importantly, I will say thank you to Resham for bringing me into this. And I'm really looking forward to listening to the conversation today. Over to you.
Thank you. A warm welcome to all of us. Let's begin. So today's topic, designing AI for low connectivity and resource-constrained health systems, couldn't be more urgent. Much of the world's AI innovations is designed predominantly for high-resource settings, but real-world health settings, especially in LMICs, often face the opposite: intermittent power, fragile connectivity, shared devices, overworked staff. In these contexts, AI must be radically rethought, not to function, but also to add significant value. We've joined today by 5 incredible speakers who bring experience from ground up across Africa, South Asia, and global institutions. Let's begin by hearing one key insight from each of them. Parallelly, I'll also request the audience to post your questions in the question and answer box only. I'll request you to not raise hands during the discussions, and speakers feel free to answer to those questions directly if you feel like, or else we'll be happy to take them up during the question and answer segment. Let's begin with our opening round, experiences from the ground. I'd like to invite each speaker to briefly share one lesson or one insight from your work that shaped how you think AI in low resource settings should have been, something that changed the way you design, implement, or scale. Anne, let me start with you. With AMREF's deep presence in Africa and beyond, you've seen firsthand what it takes to innovate in challenging environments. What insights have stayed with you?
Thank you. As you very well know, AMREF works a lot at the community level, strengthening community health systems, working within public health systems to ensure that we deliver quality services for African communities. One thing that has stuck with me is just ensuring that we make primary healthcare services a reality for African communities using AI-powered tools such as OPOCAS, the point of care ultrasounds, that have really revolutionized how care can be accessed, how you can identify high-risk mothers very early on and be able to follow them through with services in their ANC services, in their quality of care, to ensure quality of care.
Thank you so much, Anne. Making public health services a reality is much needed. Over to you, Arnab. Coming to you next. At CHAI, you work at the intersection of national programs and patient-level scale-up. What's one experience that's changed how you think about feasibility adoption or beyond?
Thanks, Resham. I mean, just to build on what Anne was mentioning, currently in public health, there are obviously major gaps in access to diagnostics, access to screening, which leads to delays in treatment, and obviously, in the case of infectious diseases, it leads to kind of transmission in the community. A lot of our work is actually on how do we use AI tools to actually improve screening and diagnosis at community levels. Now, for a lot of communities and users, let them be like healthcare workers, clinicians, or the clients or the communities, there's always this fear, like, what is this tool? I mean, does this really work? Is it using this tool, will others get to know that I have a certain condition? So there are fears that we should recognize that when you're introducing any new thing, there will be at the community level, at the ground level. I can give an example of X-ray AI solutions. So now there are a lot of solutions that can screen for TB. These are AI solutions which read the X-ray image and can give a risk of whether someone has TB or has a high likelihood of TB or not. When we were introducing these tools, both the X-ray as well as the AI solution in kind of slums as well as rural communities, firstly, the clinicians were hesitant. They were not sure whether this actually works. Over a period of time, as we kind of showed what like a week. So initially we got a radiologist to actually also read the X-rays to showcase that, hey, what the AI solution's telling is actually very similar to what the radiologists see. So it kind of helped build confidence amongst clinicians that these tools actually work. We saw that for clients, for people who are actually being screened, some of these tools were actually leading to stigma because the reports that were coming out were saying that, hey, someone might have TB, or it would kind of really annotate the lung and show that, okay, there is some abnormality here, which we realized people were like, okay, why is some people's reports having this colored marks and some like language around TB when they're still not diagnosed? So we had to work with the solution providers to kind of make sure that it's not stigmatizing community. So you really need to think of, while all of this has been developed with great intent, sometimes some of these very minor user level things really hamper adoption because communities need to be confident, healthcare workers need to be confident, clinicians need to be confident before they can adopt and really believe that something like this works. So I think I would say, like, think of the users and think of what they need and how can the solution actually solve for the problems that they are facing.
Thank you, Arnab. You've touched a lot on principal aspects, and I'm going to get to that in the next round to you. Gideon, over to you. You've been leading AI strategy at PATH with Bilal, often balancing ambition and real-world constraints. So what's one design reality that's changed your approach, or some experience that stayed with you that you'd like to share with us?
Thanks. Before I get into it, pleasure to be here. Thanks for inviting me. So I think I would like to share our experience building clinical decision support systems, or CDSS, in Kenya, Nigeria, and Rwanda. And I think that the key insight from me, particularly from our work in Kenya, is around the sheer value of user testing and like sort of trying these tools in the field, seeing how they work. Because I think for generative AI in particular, it's so new that a lot of our intuitions about how clinicians will interact with the tools that we might want to build might not be correct. And I think there's going to be a constant process of needing to refine the solutions that we're building to fit local user need. And to give 3 quick examples of that. So we built an initial pilot of a CDSS to be deployed within primary healthcare systems in Kenya. So it was there to support doctors in how they were managing their patients. And the initial pilot had a little button on the side of the interface that doctors would use to log their notes, that would allow them to talk to a chatbot to ask questions and to get some guidance. But we found that no one interacted with it. And so that was our first key insight, is that we can't really rely on a solution that requires doctors who are overworked, who have many patients to see in a day, to solicit input from a new system that they might not know how to interact with, might not trust. And so that led to a refinement in the approach, so that instead we built a system that essentially is always on. So when the clinician finishes writing their notes, they'll then get some input from the models that we have on the back end that will say this is either we have a traffic light system, so it's red, amber, or green for the level of risk, together with some recommended care actions. So that's one example of on the ground behavior changing how we need to design our solutions. Second, which is tied to that, is around alarm fatigue. So this is a real thing that I think, particularly in this space where we want to be careful about how we're deploying AI, and that might mean that we bias the risk classifications that we provide from our models in favor of the more risky, so that we're more sure that we're always catching the risky cases that do truly deserve more attention. But for a clinician, that can be super fatiguing, because they then have to manage case after case, all of them flashing up red. And so there's a tension there between wanting to give an accurate classification of green, amber, red, but also not to sacrifice the care that we need to have in deploying these systems that we aren't sure quite yet how best to use. Final point, which is maybe slightly against the grain for sort of common conceptions, I think the importance of localizing these systems is super key. And the models that we have access to aren't built for deployment in many of the countries where we would like to deploy them, particularly in the Gen AI space. But we found that localizing isn't always the top priority. So for our work in Rwanda, for example, there we're building CDSS systems that will interact with community health workers. And there it definitely is key that the advice that we're giving is locally relevant, because those community health workers may not have the skills and experience to understand the cases that they are encountering in the field. But when we use these systems with doctors, with skilled, experienced clinicians, that's less the case. They know what to do. It's more a case of nudging them in the direction of the actions that are best for care, rather than them solving the immediate problem that's here in front of them now. So that can look like nudges to take preventative care actions to prevent chronic health conditions, rather than solving the immediate problem, for example. So those are just three examples of areas where our intuitions were challenged through initial pilot testing. The refined version of that CDSS for Kenya is now in a phase 3 trial, which we're very excited about. But my take-home insight from there really is just the value in testing these things and learning from interaction with end users how best to fit the technology to their needs on the ground.
Thank you so much, Gwydion. This is really helpful. And it also transitions well to Shantanu, because Shantanu, you've been the founder of CareMother, working directly with health workers in maternal child care solutions. So in your perspective, in terms of designing or on-field adoption is critical, what's a moment or a lesson that continues to shape your work? Something that you'd like to share?
Yeah, absolutely. Thank you, Resham. Hi, everyone. Gwydion actually covered majority of the points I would have addressed as well. So very much resonates to what he said, because particularly while working with frontline health workers, our primary goal is, can they identify high risk and triage the patient at the right place? That's our desire. But while doing that, what all we are demanding from them. So I think that's one of the most important principle I believe we learned was, are we asking them to do more work to achieve our goal? And is your decision support tool, or even, for example, the information that you require to arrive on that decision is demanding additional efforts from them, that may lead adoption or challenges of adoption as well. And the fatigue that Gwydion talked about, that if we are flagging everything into high risk, then it's not that easy for a physician to address all those patients who have been referred and not necessarily track or demonstrate the action as well. So one thing was how we lead them to action depending upon the tools that we have provided for high risk identification as well as stratification. But the core component was, are we pushing them to do extra work, which will limit the adoption of the tool as well. So I think that's what we would consider as an important point from our learnings. And then we work towards simplifying those efforts. We are super cautious how and what extra effort we are demanding while offering them any digital or even AI tool.
Thank you, Shantanu. And I do see that our speakers have provided really on-ground experience. So when we zoom out to a systems level approach, and Samir, thank you for joining us today. As a lead for AI at WHO, you have an amazing system level understanding when it comes to AI. So what's one insight from a systems level view that has stuck with you that you'd like to share with us today?
Thanks, Resham, and congratulations again to PATH and OECD for setting up this thing, knowledge sharing. I think it's one of the key issues that we need to address today is the advocacy and understanding of AI as a first thing, of course. I think you've taken a good step towards that, so that's a positive sign. But I think very, very pertinent points, and it was great to have the speakers speak, bringing the ground level experience, because we talk of AI, and of course, there's a lot of flashy thinking around AI and can change the world. But really, what are the pain points that need to be addressed? And I think these are the points that were discussed earlier. So I have two sort of very systemic concerns or points that we focusing on as part of the global initiative. One is, don't bring the solution and try to fit it to a problem. And that's typically what happens. We've seen this in the e-health space, m-health space, digital health, and now with AI. Also, people are bringing solutions and saying, let's fit the solution and change the world now. I think the worst thing is the first important thing is to try to identify the pain points in the health systems, and there's several of them, and then address them. I think AI is just, as we all say repeatedly, is just convener. We can bring, and it's a great convener. I think it can solve problems. We have had issues and points such as maternal child health. We've struggled with improving the health indicators around maternal child health. We have the opportunity with AI-based ultrasound machines, portable ultrasound machines with computer vision being at the point of care to help address these things. So it's very important for the community to make sure that we're addressing the pain points in the health system. And I think that will be a big game changer in itself. And then, of course, there are opportunities to enhance the health systems. I mean, AI brings in opportunities such as procurement or surveillance, where we haven't had systems or resources to manage that. And that's where we can fit solutions to enhance the systems, but not to create additional burden layers. So that's what I think what we are looking at from at a policy level is how do we facilitate those kind of achievements in AI, or those kind of real work areas where the policy enables AI implementation to help governments enhance their SDG indicators, their help save lives, and sort of make better the health outcomes that they're looking at.
Thank you so much. Through this round, we've kind of closed the circle of understanding what's the grassroots realities, examples of CDSS tools that has worked, not worked, contextualized to settings, as well as thrown some light on healthcare problems and pain points, and also from a system level approach. Let's now move a little deeper into what it actually looks like to design and deploy AI in these environments, not just theoretically, but on the ground. And Gwydion, let me begin with you. You've already given us examples of what PATH has been doing across Kenya and Nigeria. So PATH works across multiple geographies and contexts. So how do traditional machine learning tools and generative AI compare in terms of cost, performance, and practicality when it comes to low resource health settings?
Sure. I'll maybe take those one at a time. So I think cost is the easiest. Generative AI, orders of magnitude more expensive than traditional ML, more than likely. The size of the models that people are playing with, the fact that because of their size, they have to be hosted remotely, cloud costs associated with that. It's all more complex and all more than likely more expensive. I think an important element of cost when we're thinking about LMICs in particular I think this comes back to, I saw a question about how to work in non-English languages. I think that the cost of working in languages other than English is typically higher, and that's a problem that we need to solve. The challenge is that tokenization for non-English languages, which is the process of taking the sentences that you will give to an LLM, those sentences are broken up into tokens, which are essentially words, and they are fed then into the LLM itself. And on average, if you're tokenizing non-English language text, then you come up with more tokens than if you were to tokenize the same semantic text in English. So we had this in Rwanda for the same questions coming from community health workers in English. They were cheaper to tokenize and process than for exactly the same questions in Kinyarwanda. And so that's an important thing to think about when we're thinking about cost of applying Gen AI specifically in LMICs. You'll need to deal with that. And I think as a community, we need to think about how we solve that problem. Then performance. So for this, I'll maybe highlight some interesting work that will be coming out in a few weeks from our partners at Adare. They do a bunch of really great work in the global health space. And they recently completed a sort of head-to-head comparison of multimodal generative models against traditional computer vision models for rapid diagnostic testing. And essentially, the headline finding was that there are reliability and performance challenges that mean that generative AI just isn't ready for widespread deployment from a performance point of view, specifically in the diagnostic testing space. So on reliability, API throttling can be a major issue. So for example, if your diagnostic testing solution is dependent on an OpenAI model, and if OpenAI's API happens to be down when you need a diagnostic test result due to high load, so maybe everyone in the world is interacting with ChatGPT at the moment that you want your result, that means that you then don't have access to the API that you need. And that means that you then don't get the result that you need right now for the person, for the patient sat in front of you. So that's a problem on the reliability side. There are then performance quirks. So, for example, I think they found that GPT-4, I believe it was, will diagnose essentially all cases as positive in order to maximize its true positive rate. But then that also, of course, gives you a huge false positive rate, meaning that the whole testing process is completely pointless. I've learned nothing if you just tell me that everything is positive. I suspect that could come from the fact that a lot of these models are sort of trained to be affirmative, so they will naturally sort of agree with what the user is saying. They tend to say yes more than they tend to say no. And that is a problem that's potentially solvable. You know, like it could be that we could improve the performance of generative AI if we were to, fine-tune smaller models specifically for this purpose. But currently, I think in narrow tasks like diagnostic testing, traditional ML will win. The caveat here is that generative AI is flexible. So these large language models, they're large, they know a lot about a bunch of different domains, and that makes them a good fit for something like clinical decision support in primary healthcare, because they know about the vast range of different conditions that a community health worker might encounter day to day. But doing one thing accurately with models of that size is tricky. So at minimum, if you're intent on doing stuff with Gen AI, but it's a narrow task, think small model and fine tune it well for that task would be my go-to. Final point on practicality. I think there's a lot that you could say here around the practicality of interacting with models that are hosted in the cloud, network access, that kind of stuff. But maybe I think I'll zone in on regulation as something that really does draw a line between traditional ML and generative AI, particularly because of the principle of software of unknown provenance being super critical when you're trying to have a Gen AI powered tool be approved as a medical device. So what I mean there is that the model itself, what sits behind the API, I don't know anything about, and a regulator doesn't know anything about. And if I'm using an OpenAI model, OpenAI could change that model behind the API without me knowing. And that then has downstream impacts on my health solution. And it makes just the whole process of getting regulatory approval for anything that's using a closed model that sits behind an API really tricky. And that's not a problem that we have with traditional ML. And I think until we solve that problem in a meaningful way, and that takes some innovation in the regulatory space, potentially some openness from the large model providers, the practicality of using big generative models is going to be significantly worse than the practicality of using traditional ML.
Thank you so much, Gwydion. Shantanu, I'm going to come to you next. Drawing more on what Gwydion has said, so he's touched on a lot of topics on tokenization, the flexibility of Gen AI, use of contextualization in low resource settings. So your maternal health AI solutions was designed for exactly these kind of contexts. So what were some of the key technical or workflow design choices that helped the tool succeed? I know you've touched a little bit upon not adding more fatigue on healthcare workers, but especially in terms of embedding into the public sector workflows, because you have worked with a lot of governments in India and beyond. So could you like to share a little bit on that, please?
Sure, absolutely. I can speak of the work that we have done so that I can be more realistic on the experiences. So primarily, we looked at two problem statements. Can we early identify or stratify the high-risk pregnancy so that triaging and actions can happen? The second one, during labor and birthing period, where the window of action is short, can we lead them to certain actions? So our efforts were designed, rather thought on the approach that how I can help a healthcare provider to make decision, whether it's a long window but high importance or a short window and high importance as well. And when we say that these are high importance, as Gwydion said, we want them to act, right? And then what we design becomes very important. How much data that we had to design it for also becomes an important thing. In our case, there is a support or a defined rule-based approach, which becomes the backbone for designing, the upper layer, which can help you to accelerate or in a way predict certain conditions. But primarily, we used a hybrid approach, and that was what we learned ground up. One, when a frontline worker or medical officer in a low resource setting, or let's say primary health center, or at least first referral level unit, are they able to utilize the tool for first level action, and are we able to give some explainability to it? I think that becomes very important point for them, whether they're able to understand and root back whatever we have given, either weightage scoring or a risk directly score. How do they trace, or how we are able to explain the condition to them? That point becomes an important for a decision maker or whoever is taking action for us. So while designing, I think those were important element for us, that even if not to the fullest level, how we can bring explainability to our solution. The second aspect in design, I would again go back to the workflow, because when you asked about public health system, who and where to act, there is a defined accountability and process flow. If we are trying to provide something and make that decision, or rather lead a frontline worker to act on something which actually a medical officer should be acting upon, we are asking a huge change for decision making, which is not acceptable into the system. So if you have a tool which is helping you to identify something but not able to communicate to a decision maker, again there is a problem. So while designing our workflows, we've tried to ensure that, okay, triaging and decision making are two different aspects. And when a frontline worker is supposed to take input from a clinical decision maker, how we make sure that both of them are involved in decision making. So from a workflow perspective or from care pathway perspective, I think those were important elements for us while designing the solutions.
Thank you, Shantanu. Just a quick follow-up. So you said that triaging and decision-making are two different kind of aspects. So when you're working with public health systems, how do you educate the policymakers sometimes who don't understand what you're doing or how your tool works?
So interestingly, we started with software only approach, but then we had to create a hardware software to explain that how it works, and that's where the explainability in a way, not from AI model, but even the concept explainability has to be brought in, and when we are able to showcase, here, say, let's give me an example. If we are taking data from our fetal monitoring system and some historical data to imply a risk score. If I'm not able to say that why this risk is demonstrated, some explainability has to come, then only a medical officer will be able to make a decision. So the public health system decision maker who may or may not have experienced the AI aspect, they go with their clinical knowledge and understanding. Okay, if you're saying this is a risk, let me reversely understand how it will help me to make a clinical decision. I think that's what they are looking for. And if you have validated, if you have demonstrated it with right stakeholders, I think the job becomes easier.
Thank you. I'm going to have more follow-up questions, but that's going to be in the second round. Anne, over to you. We know that infrastructure is often make or break factor, and usually infrastructure may not be as we expect it to be in low resource settings. So can you share a case study where digital infrastructure has enabled an AI solution to move from pilot to scale in resource-constrained settings? And what do you think are the critical enablers that make that possible?
Thank you. Maybe I'd start by saying that most of the AI solutions that we have seen as we implement programs has been that which has been tested at very small scale, and because not just about the infrastructure, but also understanding adoption processes, understanding the government architecture is not considered in the very beginning. So you see a lot of pilots, I would say, that are doing very well, but they don't go to scale because of that, not having that scale up process mapped out very early and engaging the right people throughout the process. But one of the examples that I would give that has somewhat gone to scale, I think, would be like the chatbots. And from our observation, it hasn't really been necessarily even public sector driven. It's because I live in Kenya, work in Kenya. We have very high phone penetration. Internet connectivity is relatively good in most areas. And whenever there is a chatbot targeting young people who 70 to 80% of the time they are on their phones, you're able to deliver whether it is messages about sexual reproductive health and rights to link them to services. In some ways, while it hasn't become a fully fledged national program, it has really gone very far to reach majority of the young people. But on the other hand, is that which requires for you to link with the public sector systems, where the challenge I've mentioned about understanding how adoption should be handled from government. Secondly, things to do with who is the payer. For the chatbots, the young people already, have the internet bundles. There's a way around it, and they're able to carry on that using the different platforms. But for other types of solutions, where the payer becomes, let's say, a pregnant woman going to a primary healthcare facility, where the low-level facilities are publicly funded and do not allow the benefits package, do not include maybe an ultrasound, then that becomes a challenge because one hasn't thought about whether it is a social health insurance schemes that are in that particular country, or if the mother is willing to pay out of pocket, and if they are willing, what that means. And then it means that only particular women can pay because of their ability to pay. So they are both instances, but where we have the young people and already very interesting content packaged that has really gone to scale without necessarily having the public infrastructure get into it very directly. Yeah. Thank you.
Thank you, Anne. And while you were talking, it was reminding me about my field works usually that happens at very low resource settings across India and beyond. I think my follow-up question to you is, I usually, when I interact with healthcare workers, they're sometimes not comfortable in using smartphones or interacting with chatbots. So how do you work around that?
I think, yeah, you're right that not all health workers are comfortable. So we have different, would I call them age groups or so? So in the health workforce, we have, the new entrants that are very, techno savvy. They'll take up these kinds of solutions very easily, mostly in cities and the like, and where we still have whether it is older midwives or clinicians. So I think it's both. And also, I think there is the whole thing about, especially in the public sector, if the solution has gone through the regulators, there's that hesitancy in terms of what does this mean for me, besides maybe not being confident to use it, but what does it mean in terms of, legislation and those kind of things, to what parameters am I allowed to do this? For example, for like the point of care ultrasound, we have mostly, traditionally it was being done by the sonographers, but as you do it in primary healthcare settings, sonographers are not available at that level. You have to work with maybe a clinical officer or a nurse midwife. So there has to be those discussions, understanding, task shifting. There has to be, guidelines and the like. So where they feel that this goes beyond what my cadre is allowed to handle, then there is that hesitancy. And not necessarily maybe also that it is new. So there are many dimensions to it. Yeah.
Thank you so much, Anne. Arnab, you've touched upon certain principles in your previous conversation. You spoke about how some tools have caused stigma and also about the importance of building confidence. So ChAI has scaled several digital tools and you work in TB and other programs. What principles have guided your work in making AI tools practical, acceptable, and also usable in low connectivity environments?
The earlier speakers have kind of covered a bit of it, so I'll try to kind of summarize kind of our approach, our thought process on this. So one is, we look at who's the user of this tool. Is this going to be used by healthcare workers, technicians, clinicians, clients, program managers? You can have various tools. Because based on the user, I think their competence level, their ability to kind of understand, follow, implement any of these tools kind of differs. We also try to understand do the users kind of recognize potential value? Do they recognize there's a challenge and there's a potential value of this tool? For example, I think Anne mentioned about task shifting. That many times becomes difficult because, let's say, a staff nurse who's never done sonography, let's say a case of a point of care ultrasound, if they now have to start doing this becomes like more work. They're like, this was never my problem. Now I'm asked to do more. Sure, there's value, but then they may not really see that value, immediate value in something like that. Vis-a-vis, if it's already part of their standard of care or standard of practice, it becomes much easier, right? Potentially they can see value in, this reduces effort or improves productivity. I was talking about X-ray and AI solutions. These AI solutions stay at the back end, right? So for a X-ray technician or healthcare workers, there's really no work, for them. What they actually see is that if I do an X-ray, I get an immediate result. I can take an action on what do I need to do with this patient. Their earlier experience before AI solutions was that, I get the X-ray, it goes to a radiologist or a medical officer, and maybe after a week, I get some result. Then I have to track the patient, and then I have to kind of link them to follow-up care. So there's an immediate value that, at least let's say with the X-ray AI solutions, that we saw with users and kind of help with adoption. The other point linked is, again, I think, what are the downsides? I spoke about stigma, right? Potentially, some of these solutions can have stigma. Potentially the process is very new or complex. I'll give an example of, there are a lot of cuff AI solutions which are being kind of developed for TB screening. Now, these solutions, again, I think there's promising initial data, but you need like the right cuff signature of appropriate duration, of right quality. And if you think from a user perspective, let's say a person who's being screened, they might have to try multiple times to get the right quality input for the AI solution to then actually interpret. Now that's, if you just think from a user perspective, adds a lot of time. I mean, the person who's being screened may not really see value of why I'm doing this. I have not really come here for TB screening. I might have come for something else. So again, all of these things really kind of hamper adoption and usability. So, and then finally, I think the question is, again, I think linked back to, what's the infrastructure and investment required if there is any additional thing required. If there's additional investment, then, from a systems perspective, you need to build a use case, you need to convince someone to kind of really mobilize that money and make sure that's actually deployed there. So if you combine all of this, it really helps you determine how easily is this going to actually fit into and get adopted. Going back to my X-ray and AI example, some of the initial solutions, even actually till very recently, the AI solutions were developed independently. What really provided, helped them kind of be scaled up is the availability of some ultra portable, really handheld X-ray machines that were introduced in the last few years in the market. But what we saw, when we were deploying these solutions, is that the X-ray manufacturer provided their own laptop for, image acquisition and interpretation. The AI solution provider had their own laptop because, the software needed to sit somewhere, or they had like a offline box. I mean, ideally, one system can actually, have the AI solution built in, let's say the X-ray manufacturer's laptop can have the software installed, and everything can be integrated. But then how things were developed were separate, and no one really looked at how all of this integrates. How easy is it to use for the healthcare worker? Because otherwise, you have multiple systems. It takes more time. There's possibility of breakage and so on and so forth. So a lot of these things become easier as you kind of try to implement them on the ground. And I think, as Gwydion mentioned, as you kind of work with users, you're able to really understand and apply these principles to see what are still ongoing challenges and how do you kind of address them going forward.
Thank you. And you touched on very important points. Usually certain tools and solutions are built in silos. So even if they are built in closed rooms or in labs, when it gets into the ground, the reality is very different. In addition to that, I think when we're working with the health workforce or even policymakers, their mindsets and their acceptance level has to be understood. Their comfortability level in using the tools has to be understood. And then accordingly, we have to work around that so that they're competent and comfortable enough to use these tools. So thank you. But in the next round, I'm going to touch more on the user aspects with you, Arnab. Samir, again, zooming out to systems level. And I know that you've touched on not making solutions and fitting it into context, but contextualizing and localization of aspects and touching on the pain points. So from your experience, what are the most common structural gaps you see predominantly in low and middle income countries that limit which AI tools can work realistically in low resource settings?
Thanks, Resham again. And again, great points by the sort of ground up responses. I mentioned about the not fitting solutions, but I think the three critical aspects that we need to consider, primarily for low income country settings, because this is not something new. We have done this. The marriage of digital and health has been going on for a long time, and how do we make it successful? I think one of the major gaps we're seeing is governance in the space of AI. And I think it's very, very important. I see a lot of questions also being poised around what are the ethical approaches that we should look at? Where does the regulation fit in? I think that's why a key focus on this success of AI going forward is how is the governance established? And when I say governance, it includes the regulations, discussions on equity and distribution of equitable and ethical approaches for AI, and the evaluations. I mean, we don't know all the answers to how AI will work, whether some of these pain points will be addressed or not, but it has to be a continuous process. And for that to happen, there has to be a governance mechanism at the country. So I think there's a big onus on how do we establish the governance for AI in healthcare at the country level. And that would define single-handedly how whether it scales up sustainably or we do the same mistakes that we've done in the past. So that's one very important point. The second is benchmarking. And when I say benchmarking, it is everyone trying to create a product does not help solve problems again. We as global communities working together have to come up with the right prototype of products that we define. I mean, it's the same thing when mHealth was there. We had ML solutions coming up with random people using content from all over the place. We have to use the right structured approaches, both on the software side, the content side, and the specification side. And the third very, very critical part in the AI space, which is slightly unique to others, is localization. If we don't localize these, we are preparing ourselves for failure because the way AI behaves, it is machine learning, it is natural, using the tokens that, as Gwydion mentioned, from a setup that is not localized will create a lot of challenges for scaling up. So I think three parameters that we are focusing on. One is enhancing and building governance mechanisms for AI so that while the innovations are happening, while the technology is being scientifically vetted, we have the ecosystem ready for that. The second one is benchmarking so that we can give the right guidance. The right guidance is available for the developers, for the countries to implement. And the third is localization. Without that, it cannot happen. We cannot adapt this whole level. So I think those are three broad level pictures that I think are critical to make successful the ground level innovations work on AI and to take them to a sustainable scalable model.
Thank you, Samir. I think that was a great wrap to round one. We understood in terms of we heard a lot of powerful examples of localized successes, challenges, importance of having principles and ethical standards, and also regulations, governance, all of these aspects. But when we move from pilots to scale, so scaling remains elusive for many AI solutions, and Anne has already highlighted these aspects before. So in this round, let's explore what it takes to shift from isolated tools to integrated systems and from pilots to scale. So Samir, let's begin with you again. Many countries get stuck in the pilot mode. They don't move from pilot to scale mode, or many solutions in certain countries. So what technical and institutional foundations are needed to move AI towards sustainable scale? I understand that you've spoken a lot of the structural gaps that exist, but when we talk from a technical aspects, what do you think could be downstream or upstream AI solutions? Do you think upstream level AI, such as integrating it within supply chains or micro planning, could quietly drive better outcomes?
Thanks, Resham. Again, I mean, going point, I think the foundational points I highlighted are critical first. I mean, technology and the technical aspects are more agnostic to the systems, and I think that will evolve. We were talking of generative AI and the challenges that generative AI are bringing in, already being addressed with the ADK models of agentic development toolkits that are coming out, can address and reduce the hallucinations in areas. So technology is evolving, but I think we have to first, the parameter number one is, again, I'm honing in on the foundational principles, the governance, the benchmarking, and the localization piece that I mentioned. The second part, again, going back and understanding where the problem sits, and how do we address those problems, and then really hitting on those problems. And so, I mean, I'm seeing the questions also. People asking, what kind of problems do we see in the health systems, and what is the scale? Problems such as gap in health workforce. We do have a massive gap in health workforce who are trained, who can be delivered. We need to address those specific areas so that we can find a way to help them. I think Shantanu and Arnab both said that we don't want to give extra work to the healthcare workers. And this is what typically has happened in the digital space and the ML space, where you gave them new tools, which meant more learning for this group. And so we're trying to help them address those administrative processes through these AI applications and systems that can be part of that. Second is, of course, the investments that are happening. The sustainable investments that the governments have to rethink. So advocacy around that has to be rethought also. Otherwise, the disconnect typical is we have the research, the science comes out, and then it dies there. So a very important part is the investment, the portfolio, the donors that are investing in these infrastructure approaches have to be kept in the discussion and be aware of such sort of approaches, because we don't want to have verticalization where research ends the innovation. And that's typically, as we've seen across the pilotitis in the past phases. So that's the second thing to look at is it's not just the technology provider, the healthcare workers, it's the whole community that needs to be involved and engaged to this. And I think this is a great effort, bringing the community of practice together to understand that situation, that we have seen science working, but then the problem is you cannot shape the market because there's no forward thinking from the market shaping perspectives. And that will only happen also if we match the problems to the priorities. And so that goes back to my earlier point. We were saying solutions are ready, but the investors are not ready to put money into it to scale up the market, because that's not a problem that they see is important, either because they're not aware or they have different priorities. So we have to match those in general as well. And this will all happen when we have the right ethical approaches, when we have the right equitable approaches for scaling up these areas, and to address the right problems that we're looking at, which is being, the health workforce gap, the costs, health costs. When we're seeing massive expenses from cancer screening, AI can bring those costs down. Can we make an impact? TB, Arnab has highlighted, is a lingering task. How can we innovate to sort of solve this final mile of TB and those things? So I think it's a very systemic approach that needs to be taken to ensure that what lessons we've learned from the past are not, or mistakes we've learned in the past are not repeated, so that we can take up some of the scale and do it one at a time. I think it's not something that we're saying we're going to change the world. AI is giving us better opportunities to enhance the health systems. I think that's what we should leverage and allow for those leapfrogs where possible.
Thank you, Samir. Gideon, I'm going to come to you next, because your next question is on infrastructure investments, and drawing more on what Samir has said, the importance of investing in infrastructure is necessary. So what do you think? We all know that infrastructure investments are always tricky because there are a lot of dynamics at play. So from your perspective, what does good enough infrastructure look like to support AI at scale? And how can policymakers balance what's feasible now with what's needed for a full system integration?
Sure, thanks. So I think I would draw a bit of a distinction between what's good enough and then like the ideal digital health ecosystem that we might all wish we had. I think the first thing to acknowledge here is that what we have today is not good enough, and it's definitely not the ideal for at-scale deployment of the kinds of systems and tools that we're talking about. And to unpack that a bit more, we have a really fragmented digital health ecosystem, which forces innovators building the kinds of tools that we're talking about to replicate their work across different systems, across different geographies that themselves have a bunch of different systems, different tools that they use. And ultimately that all prevents straightforward and easy deployment of solutions that could be saving lives, improving health. I think for a long time, we and a lot of people have been working towards, this panacea of truly interoperable digital health systems and other digital systems in the digital public infrastructure space. And that would be great. It would be neat if all the world's different health systems were truly interoperable to make for easy deployment of AI systems. But the challenge that we have, given that that isn't the world that we live in currently, is do we wait for a transformation to that truly interoperable digital health future that so many people have been working towards? Or do we see this as an opportunity for a new crop of valuable products? And what I mean there is sort of products that offer integration as a service. And so if I was a donor or a policymaker, I think that's how I'd be thinking about this. Do you invest in the long-term aim of developing global interoperable health systems? Or do you focus on the shorter term with what we currently have? What can we build that would make integration with the current health ecosystem easier? And for an example, you have Newton's Tree, which offers it's a provider neutral platform for health centers to integrate and monitor AI solutions into their workflows. A level above that, not tied specifically to health, but you have OpenFN or OpenFunction, which is a general purpose product that will automate integration between a bunch of different digital goods or digital platforms. And those kinds of tools can make it easier for innovators developing AI-based health solutions to deploy and scale within health systems without having to solve the many challenges with integration that exist given the fragmented ecosystem that we have. So I don't know where I'd put my money between those two. I think for sort of immediate short-term benefit, we definitely need some of those sort of like integration as a service to save everyone from solving the same problems over and over again. But also those problems will persist if we have no investment in the continued efforts to develop interoperable health systems.
Thank you, Gitimu. This is really helpful, and your talk actually guides me towards Anne, because Anne, in your work on early detection of diseases and nutrition, and you mentioned earlier about making PhD services a reality. So having that kind of mission, what do you think, what has helped move AI from being a promising innovation to something embedded in the PhD practices? And how has this shaped the long-term investments and thinking capacity?
Yeah, thanks for that question. I think maybe just to share a little bit about the nutrition work. It's work that we did with Microsoft, just predicting issues of malnutrition. It was at a county, you can call it a district level, just layering weather pattern data, nutrition data, and seeing what the future could look like, and working with government to see if we can do some interventions to ensure that children and women, especially pregnant women, do not suffer from malnutrition based on the weather patterns and the like, and historical data. So things to do with capacity, I think sometimes we look at public sector as the go-to mostly in terms of capacity, but based on our experience, there's also a lot of capacity in the private sector. We've learned from other sectors like the telcos in Kenya. Everyone knows about M-Pesa. So just working together with private sector and also realizing that when you use an ecosystem approach, it's not necessarily that you have to start with a public health sector. That you could start wherever that solution is best to be launched and scaled in future. That has been our experience, depending on capacity and also commitment and also enthusiasm for a particular solution. Then the second thing is about, in terms of not just capacity of the user, whether it is the health worker, but also what's the incentive. I think we have spoken a lot about the health worker being overburdened, especially at primary healthcare level, doing a lot of work, immunization, seeing pregnant women, other kinds of conditions. But I think we could package incentives that allow health workers to participate more in these solutions, not necessarily financial. In some instances, it has worked, like where we have for every ultrasound, I think 500 Kenya shillings would be like, I don't know, $3 or something. That's how much the mother pays. $1 goes to the community health promoter, then to the health worker, the nurse midwife, and then one goes to the solutions or the reagents required for continued use of the point of care ultrasound. So not necessarily financial, but we have to think of incentives that allow health workers to bring on board these solutions. Then the other issue is also about thinking long-term about financing, which we've also spoken about, seeing how we can structure the cost of this AI solution. Is it paid from the individuals, from government, right from the get-go, so that it's something that is scalable, there's continuous capacity building, and with evolving, as the technology evolves, then there's that opportunity for continuous capacity building through existing structures, like, the continuous medical education sessions that we usually have at facility level. So opportunities are there, but how do we structure this capacity building? Then the last one I would mention that I've found, especially as someone who practices, is about communication. How we communicate about AI, especially to people who are clinicians, or to communities, or to policymakers who are not who do not work with in the field of tech and the like. So I think packaging that communication, showing them the benefits, the cost savings, because we could even be, it's not, we keep saying that it is money is the issue, and we could even be using much more, but we are not able to communicate very well how much are we saving from these processes. What does it mean in terms of the health financing that is available, and even money that's already there in public finance could be unlocked to ensure that these solutions are scaled, even to, as Samia put it, equity issues to the last mile. Thank you.
Thank you so much, Anna. I think I found your focus on private sector for scaling very interesting. And it takes me to Shantanu. I also want to acknowledge that we are running short on time. So my last two questions to the speakers, and then we'll quickly move on to the Q&A section. So Shantanu, you're a private sector enterprise and you work with the public sector very closely. So to scale AI responsibilities, we all know that health data systems matter. So how did limitations in local data, whether it's access, quality, or structure, affect your ability to move from a working AI tool to something scalable across the public health systems?
Thank you, Resham. Quickly, 3 points I would like to bring on this. One, what Samir already said, the localization aspect. So even if we have tested it on a limited environment, say in India, there is a lot of variation in India itself, as well as there are examples from different sectors or even from AI or digital data points also on the variability of performance of the same tool on different population, right? So just generalizing it. And when we are trying to then replicate the same thing without necessarily a validation because it worked in a particular environment or on a particular population, replicating that is a challenge. And I think there is a genuine ask, or rather there should be a framework to evaluate the data on a different population as well, either in terms of some validation framework which helps to localize the tool, as well as give the confidence to the decision maker that the AI tools are useful in their context. The Second thing, what we also experience while working with private sector or even at a larger level in public health settings, availability of data itself becomes a concern. If your model are designed on controlled data sets and that imbalance that comes from the public health data set that we have worked with recently with one of the state government with huge data set. But when we were actually trying to come and target specific problem statements, the availability of data for those specific elements was really less. So we were talking about millions of data points, and then when actually you are trying to build on something, the data sets are not even in thousands. So how do you, even if you build, you will do a POC, but you can't give them a confidence that this is something that you should deploy at scale. So availability becomes the limitation, and I think it's a huge problem how a generation of data, and that's where a lot of AI basis is dependent on, right? So I think this is one challenge. However, in particularly things which works in isolation, where there are things in a controlled manner. For example, we talked about X-ray, or we talked about pathology. We talked about even in our case fetal monitoring. So if we have a hardware software control continuously being learned, there is opportunity to scale and adopt some specific isolated cases. But when it goes to a system level, or when you are trying to make digital public good kind of a solution, I think there is a lot of risk associated there. The last piece I would bring is on data related, but also economics related, which affects the adoption and scale. Is there is a switchover cost for a government. There is something that is happening on decision basis, and if we are saying that because we are adding a value and there is a better accuracy than the screening level because of AI, it can also become available everywhere. At large level, let's say at a country or a state level, can we bring down that cost to the equivalent of current costs? Then only the switchover becomes more realistic, whether you are using AI or not. And these are some examples I have seen or interacted at decision makers level, where when you are able to bring a different business model altogether, because what majority of the solutions that I have seen, when they are operating with a hardware and software combined diagnostic or monitoring solution, and the whole system has to go into the current adoption to work and give those benefits. So for government or for public health system, it becomes very difficult choice. So pilots keeps happening, and then we keeps demonstrating the benefits, but scaled adoption requires various financing and use case building, which is a long-term process. I hope I addressed that. I'll pause here. Thank you.
Thank you so much, Shantanu. That was definitely very helpful. Moving on to my last question to Arnab. Arnab, you've already answered this question in terms of the user level experiences and what challenges people usually encounter when trying to scale AI in low connectivity environments. I think my follow-up question to your answer earlier would be, what key lesson do you think would you want to give to developers or policymakers as a key takeaway from a user level experience approach?
So I guess what we've seen, it's very, I think once you've able to demonstrate the value and use case, people, healthcare workers, clinicians have a ability, or they suddenly start trusting these systems. And there's also sometimes they trust it too much. They trust it blindly, and they kind of just remove some of the guardrails and kind of considerations that they might have before using it, let's say, scaling it up, which is, I think, something which policymakers and developers need to be cognizant of. I mean, it's just from a human behavior perspective. These solutions, while great, and some of them are validated, approved in country, but there's also this need for continuous monitoring. Like, for example, again, going back to the X-ray AI solutions, they have a certain threshold. If the score is above that, it's categorized, let's say, as possibly someone has TB. Now, setting that threshold is, manufacturers might recommend something, you might do some clinical validation and set that threshold, but that needs to be monitored. And as programs scale it up, generally that's ignored. Like, is that threshold still relevant for my population? For example, let's say maybe your incidence of that disease is increasing or decreasing. So maybe you need to adjust that because to the earlier point, it might lead to more people being suspected of, let's say, TB, but which leads to more cost for the health system. So there are these adjustments and fine-tuning and monitoring that needs to happen. Now, that this is a complex process, right? I mean, policymakers may not understand the nuances of that. And I feel developers need to think through how can their solutions really make this process much more simpler rather than it being a manual, cumbersome process, which it might result in it never being done. But how can you build internal guardrails or internal systems that these checks and processes are being done, the feedback sent to, like, say, decision makers, program managers, so that necessary tweaks can be made. And if everything's okay, let's say on a regular basis, that's also important feedback that, hey, the AI solution, the system's still working great, there are no changes required. So I think that's something which is, again, complex, I recognize, but something to be considered and thought of as these solutions scale up.
Thank you, Arnab. To all the speakers, I want to be mindful that we have hit our 75 minutes mark. So if you do have time, it would be great if you could stay for the next 10, 15 minutes to answer questions. If not, we totally understand. So just want to let you know that. Thank you, Arnab. Let's quickly move on to question answers. Speakers, feel free to take up any question you would like to answer, or I can read it out and then we can answer that accordingly. I do see that some of 11 have already been answered. So does any one of you want to answer anything in particular?
I would want to comment quickly on one thing which partially addresses some of the ethics or the validation part of it, because the fundamental aspect of machine learning that it's learning, and I heard a very nice quote from a professor from EPFL. She mentioned that there is an ing in machine learning, and we validate it, deploy it, and then it keeps deploying. However, the ing part is not validated again. So it will be very important to look at the aspect where we continuously validate, and there should be some more helpful framework or tools for decision makers to see if how continuous validation of the models keep happening. Otherwise, we don't know what that black box is doing eventually. So that needs to be addressed as well.
Thank you, Shantanu.
There are some tools I will share after the panel discussion. Maybe we can share with the audience as well.
Sure. Also, feel free to share your email addresses. If anybody would want to reach out to you, can do so. So I'll start with the first question. How did you bring the solution provider, the health practitioner, workers, etc., together on the use case and solutions? Would anyone want to answer this? Gwydion?
I can share a bit from our experience with the CDSS tools that I mentioned. So in each of the three countries we're working, Kenya, Nigeria, Rwanda, approach was slightly different. But in general, each of them began with a strong effort from, so there was PATH involvement, we had a local technical partner in each country as well, and then a lot of engagement with the relevant ministries of health and or their community health programs, all to collect data to power the solutions that we were going to build. I think it comes through in a few of the other questions that are in the chat that essentially we need data, right? Like there's no way around the fact that to localize, you're going to need realistic, to high coverage, representative data sets that you can use to tune the models that you might want to apply for a particular context. And we very much tried to bring everyone together to collect that data. So it was a sort of collaborative approach of developing the right method to generate the data. Eventually, we landed on the data would come from community health workers themselves. So frontline health workers would record questions that they had about cases that they encountered. Those questions were then answered by local clinicians in country. And so we had like hundreds of question answer pairs that were locally relevant because they were generated by local health workers. And then we worked with local innovators. So in Rwanda, we worked with Digital Umuganda, who are a great team working on localizing AI models for local African languages. And so they ran a lot of the sort of evaluation process for applying models to answer the questions that we had from community health workers. So I think it's a lot of that kind of work where there will be a bunch of people in the countries where you want to do work that are interested, have the expertise, and have the experience to add a lot of value. It's about having someone to do the convening and bringing people together, which we were lucky to be able to do. And in general, I think interest is high. The skepticism that exists is good and it's useful. And the way to manage it is to generate evidence. Like if we can show that things work, great. If we can show that they don't work, also great, because we're not deploying something that doesn't work. So yeah, that's just our approach, but curious if others have experience from doing that kind of stuff.
Thank you so much, Gwydion. So there is one question: how do we ensure that organizational capacities are built to utilize and leverage these tools? What are some ways you have done this with your partners? I think it's focusing on organizational capacities and partners.
I mean, just to complement Resham, I think it's a no-brainer. Again, this is not different for AI. This is something that you have to foundationally build in. And as I mentioned, if you're looking at scaling up solutions or implementation of AI or digital solutions, capacity is important. The community is not intrinsically trained on these solutions. So working with different stakeholders, health, technology, the end users is critical in designing and deploying the solution. So I think that's a very important part, and how to do it is partnership, collaborate. Don't reinvent the wheel, collaborate. I think that's a formula that should never be forgotten.
Thank you, Samir. As a key takeaway, what are the focus areas for research that AI in health should focus on for the next 5 years? Anybody would like to take that up?
One quick thought. I think there's so much that you could say for this, depending on your angle. I think so. We or I at least think a lot about how do you actually use generative AI in a way that's useful. And I think in general we could do a better job of keeping up with the evolutions in how generative models are applied to perform specific tasks well. So the world is moving away from using one big, large performant model to do things. Instead, we're moving to a world where we have collections of smaller, maybe not smaller, but definitely more specialized agents that are doing one component of a task. And then those agents are combined in unison to do the whole thing very well. So if you look at Google's co-scientist, it's doing this. It's broken up the scientific method into a bunch of discrete tasks, hypothesis generation, review of those hypotheses, various other things. And those agents in concert do things very well. And I think in general, we in the global health space could learn a bit from that. So we could think about, and some people are doing this, maybe it's us that are a bit behind the trend, but yeah, we could learn a bit more from the cutting edge in AI to figure out what's the next best way for us to apply those methods to the specific health areas where we want to do work. That would be my thing.
Thank you, Gideon. This is going to be my second last question. It's from Judith. Women in Latin American population is outside of AI training. This should be a part of prospective programs. How can this be solved? Anybody? Arnab?
Completely agree. I think there are a lot of population groups that are currently not part of, let's say, AI training or deployment. And I think some of the speakers have covered how some of these models are actually trained on certain populations, and then they might be used in different population settings. I guess the only way to kind of address some of these things is what speakers have also spoken about is localization. How can you kind of make sure there's greater localization of data, there's greater validation in country for relevant solutions? Everything need not be tested with every population, but I think really understanding for a certain population group, what are the key challenges, what are the right AI solutions, and then generating local data, making sure the models are trained on that become very critical. I think, again, it requires a lot of collaboration between the solution developers, governments, other partners to make sure that this happens in a both rigorous manner and in a very kind of thoughtful manner, I would say.
Great. Thank you, Arnab. I think that was my last question, and we're just 4 minutes out. So I'll request Eric to please give your closing remarks, and I want to thank all the speakers and the audience here. Over to you, Eric.
I think this is absolutely fabulous for a kickoff. So thank you to the panel, and thank you to Resham for organizing and fantastically facilitating such an important and critical topic going forward. Thank you to everyone in the audience too, because we have had, frankly, more questions than I've seen at the average webinar like this. So I appreciate everyone's curiosity, and I think it's going to be really a fantastic kickoff to our overall series. I particularly enjoyed the comments around the need for better governance and benchmarking and localization that Samir talked about. I will remember the term around alarm fatigue that we are all experiencing. And I do think that a big part of our critical success factors for this are going to be around the capacity for partnership across public and private sectors that Anne was talking about. I think that is certainly one of the areas that we have to meaningfully unlock that I'm hoping that we can get to in this series. So stay tuned. We will be having another webinar in a month that will be focused on from use case and to scale culture, embedding AI in public sector practice. And that really is focusing on the need and imperative to scale. Bluntly, nobody is doing scale well globally. So I think there's a lot that we can learn in order to do so meaningfully and effectively in order to really unlock the value from AI, again, for economic prosperity and, more importantly, for human prosperity in a human-centered system. So with that said, thank you all. Look for our webinars. We'll be posting them up on YouTube, and you'll be hearing more in terms of what we're doing going forward. But aside from that, have a fantastic rest of your days, your mornings, your afternoons, your evenings.
Thank you so much.
Thank you, everyone.
Thanks.
Thanks
Take
all.
care.
Thank you. Bye-bye.